Welcome to Progenesis Academy webinar. This is number 10. Thank you for your continuous support. Today we are having a very interesting roundtable discussion this is a discussion about IVF treatments during COVID-19 from a patient perspective. We're very pleased to welcome our panelists of experts. We have with us Dr. Turkaspa. He is the President and Medical Director of Institute of Human Reproduction. We have with us Dr. Hirschfield. She is a physician, fertility specialist at Fertility Centers of Illinois. And we have with us Barbara Klura. She is President and CEO of Resolve, the National Infertility Association. Thank you so much for joining us. We have approximately 90 patients with us on this webinar. We also have a large number of IVF professionals. So the webinar is going to be about IVF from both perspectives, the patients and the IVF practice. And I would like to start my first question to our panel. And we have with us Chelsea. Chelsea is representing the patient perspective. She is an actual patient seeking treatments at the moment. And we have Miriam, which is going to help us ask those questions and channel the questions directly from the patients and from the participants directly to our panel. Thank you so much. Let me start with the first question. How is your practice adjusting to COVID-19? This question is for all our participants. And I will start maybe with Barbara first.
Hi, thank you so much, first of all, for doing a panel on patients and for including myself from Resolve and Chelsea as well. It's just an honor to be able to share the patient perspective. So I am the President and CEO of Resolve, the National Infertility Association, and this pandemic and kind of the crisis for our patient community has really impacted our organization. We're a small nonprofit, but we have a very wide reach. So we've had to deal with all of the issues associated with a small organization, nonprofit, fundraising, etc. But in the midst of all of that, the community we serve it just had their entire world turned upside down in a way that, you know, it was just really quite overwhelming. So immediately our focus was on the patient community and putting out really support resources. We recorded several webinars right away. We launched virtual support groups. We have about 200 in-person support groups every month that could no longer meet. So people who were relying upon that support, it was gone. And so really it was completely retooling how we provide our support and information. At the same time, trying to stay ahead of what was happening with the medical guidelines, what governors were doing, and trying to figure out our role in all that as well. So it's to say the least, it's been a really tumultuous time for our community. And you know, our goal is really to be there for the patient community and provide support and information as best we can.
Fantastic. Thank you so much. Dr. Hirschfield.
Well, hi, I just wanted to echo what Barbara said. Thank you so much for including me. It's a true honor to be part of a panel focused on a patient perspective. I'm a physician in Chicago. I'm at Fertility Centers of Illinois. I'm the co-medical director of IVF Lab as well. And so I would say, I would just agree with everything Barbara has said. I mean, from a logistics perspective, clearly this has been a challenge because we want to make sure we not only provide excellence in fertility care, but we want it to be safe. And we know anytime someone leaves their home, there are exposure risks. And what we do not want is our clinic to create an enhanced exposure risk. So it was taking a very large practice and implementing social distancing, minimizing anyone in our office at any one time. And I have said to many patients, I would say that we have gone from priding ourselves on convenience to very honestly, we're not so convenient. That people are waiting in their cars. If for some reason there's more people in the office, we've spaced out our times. So you can't always get your favorite. I think this is the necessity. it's a different experience for someone who's done fertility before. Our clinics feel like a ghost town, very honestly. We have decided to screen all of our patients for COVID-19. We've offered screening to all of our staff. And so really what our goal is to do is not only to bring back fertility treatment, but to bring it in the safest way that we can. So the goals of screening our patients has been twofold. How do we minimize the risk that somebody would conceive immediately in the context of COVID, but how do we minimize those in our office that are asymptomatic? How do we truly minimize to different levels of exposure risks? So that has been something that we have taken on as well. We have really made efforts to be proactive in communications and created a task force. We took our psychologists and made them Zoom. We've taken our support sessions and made them Zoom. All medical visits are telehealth. I have to say that piece of it I love. I think patients love. I think we've learned it's kind of nice for people just to go somewhere for lunch and be able to have a half-hour consult without having to schlep and drive and park. So if there's that silver lining, it's maybe we can retool and rethink how we do medicine. Making people come to our office so much is really inconvenient.
Very good. Thank you so much. Dr. Tukaspa?
Yes, so I'm Ilan Tokaspa. I'm the founder and co-medical director of the Institute for Human Reproduction. We have offices in Chicago, in Oak Brook, in Illinois, and in Valparaiso, Indiana. And I would like to say that I think that there's two different perspectives that we should talk about it. One is the patient perspective is what they feel and how the uncertainty of the journey. And with the COVID-19, it's just another somebody that actually all these emotional roller coasters that they go through the treatment, now there's COVID-19 and the uncertainty and the stress is growing tremendously. And in addition, so those are the main issue, and I think that I'm happy, thank you for the invitation. We couldn't have a better topic to talk about patient perspective, because actually everything we are doing is trying to help patients to achieve their goals, is to get pregnant. The other thing is technical issues. So the technical issues are very important, but we have to make it in a way that it will not interfere with the patient's life, as to make it as less as possible interfering with their life. We need to protect the patients. We need to make sure that it's secure for the staff. So those are everything else that we're going to with regards to social distancing, is wearing a mask and checking temperature and all those things, which I think that everybody has learned how to do it. From what we found out, with all the measurements that we have put in place, patients really appreciate it, like it. They come on time, the service has been performed, a blood test, ultrasound, whatever tests they need to do is a physician in the office, and they leave. And we continue to do video consultation, phone consultation, and I call it a personal consultation, but by video and phone, because it is a personal consultation. So it may be a wrong acronym to use. Social distancing, we should have called it physical distancing rather than social distancing, because it's against our nature. But I think that altogether, from patient perspective, it's on us to make it, all those technical limitations, to make it as less frightening, as less separating, because it's really, if I meet a patient for the first time and we may talk on the phone, and the next time she will see me in the clinic and she's with a mask and I'm with the mask, so what's going on? Who is this guy who is coming to take care of me? So I think that we are very good in trying to relieve the stress and helping them. And I'm sure that while we talk during the day about all the questions and answering that, I think we will make it simpler as possible for everybody to go through.
Very good. Thank you so much. Chelsea, you are a patient. You are currently seeking IVF treatments in the middle of your treatment. Are you concerned about COVID-19?
Absolutely. To echo Dr. Turkaspa, the normal process is emotional enough, and it's such a roller coaster, both physically and emotionally. And then you add the context of a global pandemic on top of all of those feelings, and it is extremely overwhelming at times. The amount of information that is still unknown is very scary, to be frank. And I think that to add that level of unknown on top of everything else that I've been feeling as we go into our first round of IVF, it's very anxiety inducing, and it's very complicated at the same time. I think that the normal IVF cycle is just a complicated thing to sort of cope with and go through that roller coaster, and then you add this and it's intense.
Very good. Thank you so much for the perspective. How do you guys help patients reduce their anxiety? Patients that are going through treatments with a lot of uncertainty, how do you manage that? And I'll start with you, Dr. Hirschfield.
Well, I think one of the main things that has been helpful is the ease of Zoom, right? Or the ease of the telehealth is the consultation does not have to be far and few in between. I have to say, I think, I love Dr. Turkaspa's expression, we are not social distancingly, we're physically in different spaces, but we are doing virtual hugs and handshakes. And I feel like really advocating for people and close contact is key. I think that's a key piece of it. I think what has always been a priority for me in my practice is this idea that COVID-19 is a whole nother level, but we know that the stress of infertility is real. We know that when we look at dropout for patients with infertility, one of the highest cited is stress, emotional distress, even when finances wasn't a concern for state-mandated states. And so we as a group have partnered with different programs. So I showed in the past that yoga has demonstrated a diminishment in sort of certain stress markers. And so trying to recreate some of these virtual supports. I think also as well as really trying to find ways that we are reachable. And so the portal, phones, Zoom consults, I think those are key pieces, and so that patients appreciate that A, they're not alone, that we're in this with them, that we're providing them the most updated information as we have it, and that it is hard, it doesn't matter, I mean, no one in this world is untouched by the uncertainty of COVID-19, that's an impossibility. I think what it has allowed us all to do ideally is to focus on the here and now, to really be present in the moment, and to help, I think, patients potentially have that perspective, whether it's with our tools, psychologist, yoga, meditation. I think those are the key pieces now so that people can manage the stress. The stress is real. I mean, infertility is stressful, there's no question, but going through a pandemic is stressful. And so we have to make sure that we're managing that stress. We're not enhancing it.
Mm-hmm. Thank you so much. Dr. Turkaspa?
I think that I see it in a way that my role as a physician is actually to try to make it as easy for the patient, the journey that she's going about to. Part of it is set up expectation. Now, in addition to set up expectation with regards to what is the chance for her to conceive, is also to set up expectation, what is my risk to be infected by COVID if I come to the clinic? Is the clinic have done their risk assessment has tried to make it as safe for me to come there? How they keep their staff healthy also, because it's important for the staff as well as for the patient. In addition, I think that this is a main question is, can COVID-19 infection be acquired in utero? So, because at the end of the day, our patients, or everybody that come, they don't come for diagnostic tests or treatment. They come for a baby. And we have to remember that. So at the end of the day, now they want to conceive. And now what's going to happen? It's a different uncertainty. And of course, they worked so hard to get pregnant. And now what will we do? So I think that this is something that I'm sure that we are going to address that too. So this is a very imminent concern. Just to say, just to stay calm, everybody, most probably it seems that everything okay. There's still some case reports that may suggest differently, but altogether, the vast majority of the data that we currently have, it seems that there's no major effect on the health of the mother as well as on the baby during the pandemic. But I think that if you take all those pieces together, and if you brings information, keep contact with the patients, and whoever needs an extra care, make available our psychological services and things like that, then altogether, it's okay. I'm not sure that we are going to start now a yoga session for all the patients. I mean, whoever wants to do yoga has already been doing it. They don't even need to start yoga. if I find that this will help, I'll be happy to do that too. But I think that we can find, we can adapt, and we can suggest, and every woman and male. They don't forget, the men also under stress sometimes. They don't necessarily show it as well, but they are under stress. And altogether, we need to take care of the couple or the patients that comes to us.
How about the other emotional supports? I know Barbara has an insight on this because she has conducted a lot of surveys and she knows exactly what patients think. Barbara, would you be able to share with us your insights of, do you feel clinics have supported patients, particularly in the emotional support?
Well, it's a great question, and we did conduct a survey. It was closed kind of right at the point where clinics were starting to reopen, and so it was sort of that end of April, beginning of May time period. And we had over 550 people fill out the survey. And one of the questions we asked them was questions about, we had statements about their clinic and their interactions with the clinic, primarily during the closure. Things like, you know, were you in regular contact? Do you feel that you were provided information? And things like that actually scored really high, where patients agreed with those statements. And then one of the statements was, you know, my clinic provided me with mental health resources. And 60% said no. And so I took that and I thought, well, wait a minute, what's going on here? We're dealing with already an infertility journey that, as both of these professionals have very clearly articulated, is a journey that already is high anxiety, a lot of stress, and then you add this, you know, global pandemic. And honestly, we should be, you know, overcompensating for the mental health needs. I mean, the data amongst the general population right now is sky high for anxiety and depression. So I'm not pointing fingers, but I think this is an opportunity for all of us to really understand how important those mental health resources are. And it's great that a practice might have in-house mental health professionals. That's the ideal. But there's a lot of other resources out there as well, including Resolve, you know, support groups. Look, we all have different, maybe sitting down with a counselor isn't the best. Maybe you want to talk to peers. So I think there are a variety of ways. I love what both of the physicians have said, though, about making sure patients have the information they need, how to lower that anxiety and how to lower those concerns is what I like to say, over communicate. And how are you really on a personal level communicating with your patients, answering their questions. I love the comment about expectations. Everyone is going to be different. And I'm sorry, but it's going to take time and resources to do that outreach. But there are ways to make sure that your patients have available resources. They're not all going to take it, but at least to be able to say, actually, yeah, they did provide me with a lot of ways that I can get support right now. And the patients that we surveyed at that moment didn't feel that way.
Very good. Chelsea, go ahead. Sorry about that.
Sorry. I think this is a very important study. And I think that if out of about 550 patients, about 60% feel that they don't have enough counseling with regards to their stress level, it's on us, on the physicians and the practices to make sure that we are doing better. I'm going to recheck how our patients feels today, but as I mentioned, we actually were very active from day one to be in touch with the patients, to call them, to send them messages, to update them about what's going on, not just in our clinic, but what's going on with the ASRM recommendation, the American Society for Reproductive Medicine recommendation, how it will affect our activities, offering them with the mental health blog and information and what's available. And we have a psychologist that we work with that has a lot of experience with mental health. She's actually the vice chair for the mental health group of the American Society for Productive Medicine. So we should know what to do. So we are trying to take this very seriously. And actually, the feedback that we get, at least from our patients, that actually they are very satisfied with everything that we have done for them. But at the same time, I think that we should always look and see what else we can do and how we can improve that. And this is I think, with the results of your study, actually every clinic should look at it and see what we can do better for our patients.
Thank you so much. Yeah.
I would just agree. I mean, I think that it is, when you meet with someone, you're in an interaction, we're receiving very similar feedback. And I think the logistics, clearly, as Barbara has identified, were very well communicated. I think we as a field, though, overestimate our effectiveness to assess and manage stress in the context of a consultation that we're talking about all of these other things. I think we have to team. We probably always had to. COVID-19 is forcing an issue that perhaps should have been at the forefront for a very long time, knowing how stress impacts patients' journey, knowing that stress causes people to drop out of treatment. If you drop out, our pregnancy success is 0, right? That's not good for anyone. So we got to keep people in clinic. And I think it is hearing people, making resources that we have be known. We had these 4 o'clock sessions, open sessions, but maybe what we're providing isn't what's meeting people's needs. So I really applaud your efforts, Barbara. I think this is what's going to help us beyond COVID-19 to change the patient experience.
If I may, just one more thing, I'm sorry. I'm not sure whether you should push patients now to continue treatment. Some patients, it's been very difficult for them. And with the COVID-19, this is like the straw that may break the camel back. So I've talked with many of my patients, and some of them, very few. When we felt that the stress level is high, I offered them, why won't you wait another month or 2 before you come for treatment? Even though they were about to start IVF cycle in 2 days, back in mid-March. And they actually said, thank you so much. They called 2 to 4 weeks later and said, now they're calling after, we started in May, now we're almost in June. And they say, hey, can I start, and I feel really great, and can I start tomorrow? So I think that sometimes we do need to get to the legitimacy to those patients and say, do you want to wait a few weeks? I don't think they should wait another year or 2. But do you want to wait a few weeks? I think this is the right way to do.
Very good. Thank you so much. Chelsea, tell us about your personal experience. Did you feel like you had enough supports while contacting your clinic, emotional supports and any addressing all the concerns and anxiety?
I do and I don't. I'm finding both the clinical support side as well as the personal support side it's not exactly what I expected. And I didn't know what I needed until I needed it. So going into this, I'm finding that most people don't know how to adequately support someone going through an IVF process. And then you add the context of the pandemic and they really don't know how to support somebody going through it unless they've gone through it themselves. So my support group for this in particular is very small, just because those who are uncomfortable with it or they're not really sure how to support me, it almost makes it worse as they try and stumble through that. So I really only talk to a couple core people. In terms of the clinical side, I do wish that I would have been contacted earlier with, this is what's happening. These are the next steps. This is what the delay might look like. My husband and I went back and forth on, do we want to delay? And really it came down for us of, I'm reaching the high risk age to begin with. This is our first cycle, so we haven't gone through one yet. And it's that battle of delaying starting a family or pushing through and hopefully nothing happens because of COVID-19. So I think that everybody's journey is so different, and the clinical response to that mental health component is not a one size fits all. So I think what both the doctors have touched on of just being there and over communicating and being there as a resource for that mental health component specifically is really, really important.
Thank you so much. Before we get into the next question, which will be about the risk assessment of COVID-19 during IVF treatment, I would like to get the questions from patients. We had more than 16 patients sent us questions, and Miriam will maybe put a couple of questions. Because we have a large number of questions, maybe we're going to have each physician answer one question, and we will do maybe two questions to each, maybe 4 questions, and then we'll continue the process forward. Miriam? I think you're muted.
Sorry about that.
No problem.
We have a question coming from Shanley. She just turned 40 and is about to embark on her 5th retrieval cycle in the past year. So unfortunately, she has to travel about 4.5 hours by car to get to the nearest fertility center. And she wants to know if you have any advice of when it comes to undergoing treatment away from home and choosing a hotel during this time, and if it's worth it to risk to proceed with a new cycle during the pandemic. And then if you just had any advice on any precautions she can take to keep herself protected. If we can have Dr. Terkaspa answer the question.
We have a unique clinic, I would say, because we also treat many patients that comes from all over the US and sometimes from across the world, for treatment, not just for infertility, but also for like pre-implantation genetic testing to avoid significant disease in the family. So traveling is a main issue. Now, so we have worked with many patients and many clinics during the years in order to avoid traveling. And we have found out that if you allow the patient traveling 4 or 5 hours each way to have the monitoring and to do it 3-4 times during the cycle is really very difficult. So for instance, you can use for blood draw, these LabCorp, Quest, other lab, we use LabCorp now. You can go, and in many places you will have a lab, somebody is there that can draw the blood and take it, and usually it's within half an hour to an hour drive. We can always accommodate an ultrasound test with the local gynecologist, at least for the beginning. We do want, then we can say, you know what, why won't you travel just like after 8-9 days of stimulation, because usually when you go through ovarian stimulation, the egg retrieval in average is about 10 to 12 days after you start stimulation, different protocols, etc. And also definitely, if I have treated one patient for once or twice before, and definitely 5 times, we should have some knowledge on what to expect, how she will respond. So we can actually bring her for a day or two before the trigger shots to come for the clinic for blood and ultrasound in the clinic to reevaluate. So the traveling and staying, and then she goes for the egg retrieval, and after that depends whether she's doing fresh transfer or not and things like that. So those are the things that can help significantly with the traveling for monitoring. How she should protect herself, wearing a mask, social distancing, avoiding any communication with somebody that may be infected, and if there is a question whether someone was infected or not, then she should encourage whoever is a possible whoever is a person that was possibly got infected to be tested, or she should be tested herself. These several companies, and now you can test the blood, you can test swab from your nose and throat, you can do also sputum, and you can actually collect it, FedEx it, and get the results within 2 to 3 days. So I think that this is very important, and all those things will protect her as well as the family and the clinic.
Very good. Miriam, can you give us the second question?
Yes, so second question is from Ellen. She asks if there are any updates from ASRM on when FETs can resume and if COVID-19 can be passed through semen.
Dr. Hirschfield?
Sure, please. So I think ASRM has provided guidance to say that treatments can be resumed. They're pretty broad, including frozen embryo transfers. I think some of the things that they've highlighted is identifying patients that potentially have higher risk of when they obtain, or God forbid, if they get COVID-19, that they would have a more complicated course. And so I think what's interesting is really identifying not necessarily the type of treatment someone is doing, but somebody who's obese or poorly controlled diabetic or on immunocompromised medications like steroids for a long time. These are the people we want to potentially delay. And I think what ASRM is really trying to identify is all of us have regional differences. So I'm not sure where the individual who lives asked this question about frozen embryo transfer, but looking at our state guidelines, our local guidelines in terms of incidence, when people are bringing back certain types of treatments. But ASRM is definitely broadening their guidelines and allowing clinics to make those best decisions based on where they're located. I think in the question of the semen, there's now been a series of studies. I think one was in JAMA, one was in FNS. In the initial study, there was a thought that sperm was, COVID was identified in the sperm. The follow-up study did not show that. And I think some of the criticism of the initial study was one, that the testy blood barrier is not perfect. And so it's hard to definitively say this truly was from the semen versus theoretically from the blood. There was also some question about the specimens were obtained as these people were in the ICU. This was not a healthy individual trying to conceive at that time. So it's a very different type of patient population. The follow-up published more within FNS was really looking at more healthier individuals that were able to create their own specimens, in which case COVID-19 was not seen. I think in both of these studies, though, the numbers are incredibly, incredibly small. And so what this identifies for us is that it is so important to actively be studying these things, but it's almost reckless to be making conclusions for patients 20, 15, 30 at a time. We want to be mindful of what it's showing us. We want to do our due diligence. But these two very different studies looking at people, quote unquote, with COVID, but very different experiences, showing different results, just highlights that. So I think that it's hard to say definitively that COVID-19 could be identified in sperm. I think there's been a study that suggested it, but it had its flaws. I think we need to continue to ask these questions and study these things so we can provide those answers.
Very good. So before we go into the next two questions, I'll ask Barbara a question related to what we were talking about. And you're, Barbara, you're leading a Resolve, which is a organization that is dedicated to patients and advocacy of those patients. We have heard from certain clinics that they were trying to get their patient tested with COVID-19, but COVID-19 was mainly prioritizing patients that are symptomatic. How do you feel about that type of restrictions that IVF patients are not able to take the test, that they don't have that same availability and they are going through a process of fertility that is already very stressful?
I think we all agree that with COVID-19, what's happening today is very different from what happened last week and what's going to be happening a week from now. So on the testing front, I live here in the state of Virginia, and we're one of the states with the lowest number of testing per capita. And so it's been something that just as citizens, we've been very cognizant of and aware of. Whereas we see in other states, asymptomatic people can drive through a parking lot and get tested. So I think we're seeing such a difference in just the last couple of weeks regarding testing. I have heard of practices that are testing every patient before they do IVF. I've heard of others that are doing an assessment and then determining whether there might be some risk in testing those patients. Honestly, I can't think of a patient who wouldn't immediately adhere to a COVID-19 test before going through IVF. We already go through so much. Add that to it, go right ahead. And so, from my perspective, that ability to have that test before a medical procedure should be available to all. And you know, honestly, it should be available to anybody who's having any kind of medical procedure, but certainly something where you know, you want to know, was I or wasn't I positive when I conceived, and so forth. So, you know, if that becomes an area of, gee, these folks can't get tested, then, you know, that's certainly something that we want to know about. But I'm hearing that it's available in many places, and some it's getting there. So I don't know that we can jump to conclusions that this is the way it is. I think we're moving as a society towards massive testing, and certainly as you interface with the medical field, wherever that may be, it will be commonplace. And I hope it becomes absolutely commonplace in the IVF center.
Fantastic. Thank you so much. Miriam, let's take the other two questions.
Yes. So the next question is from Tracy. She is 39 years old and she has 2 healthy embryos. She would like to know whether it would be safe to continue with her transfer during the pandemic.
So as we talked about it, currently the American Society for Reproductive Medicine came out with recommendations that it's okay to do transfer, assuming that it's okay to continue treatment everywhere in the specific geographical area. I would like us to emphasize that actually when the ASRM came with the recommendation not to do transfer and not to perform inseminations, actually it was the only society in the world that recommended not to conceive. There was no other societies that actually take care of pregnant women, like the American College of Obstetricians or the UK Obstetrics and Gynecology Society, or in European countries, that actually came and say, everybody, although for now, for a month or 2 or 3, don't get pregnant until we know what's going on. Nobody ever said that except the ASRM. And following the ASRM and the European Society of Reproductive Medicine also said the same. And then suddenly we found ourselves that only you cannot get pregnant through IVF, but if you can get pregnant on your own, go ahead, no problem, continue to do the same. So, well, of course, stay healthy and safe and all those things. So I think that right now, we, at least in Chicago, we are starting treatment we already started treatment for insemination and for frozen embryo transfer and fresh transfer. We are discussing with the patients the ways they should keep safe. Doing testing is offered, is not mandatory, because we need to remember that if we test today and it's negative, first of all, it takes 2 to 3, 4 days to get the results. Second, she will come in and out for monitoring, and then the transfer is going to be in about 3 weeks. Those 3 weeks, it's been a lot. Actually, she's not in quarantine because she actually comes to the clinic at least. She gets out to the clinic for testing, but so it's definitely it's not quarantine at home. So now may give you a false sense of security, which actually false. And with all those false positives and false negatives of every test that there is, altogether, the best idea would be that, yes, we can test somebody, and every time they came to the clinic, we can do a test and we get results, and everything is clear cut, yes or no, we are infected. But for now, it's not happening. Those tests are available only for hospitals, for taking care of sick people. And I think that hopefully in a month or 2, those the way we practice may change a little bit with testing for everyone. Right now, it's not happening for everyone. It's happening for specific reasons. But it's okay to try to conceive.
Thank you so much. Before we jump into the next question, just to make a comment on the rapid test, I think you're referring to the rapid test. The issue with the rapid test is when you look at the antibody testing, it was reported to be 30% accuracy. It's highly inaccurate, as far as sensitivity. And when you look at the RNA tests, like the Abbott test, the media was reporting about 50%. So, you know, I don't know if that is the best way to go about it at the moment. I think you'd rather go with a laboratory test that is known to have a certain accuracy rather than go on the rapid test side. But this is just a little comments. Let's go to the next question for Dr. Hirschfield.
Yes, so next question is not COVID related, but Sonia is 43 years old. She went through her first IVF cycle and was successful and was able to give birth to a healthy son. She then went through 3 more cycles and was unsuccessful. So she would like to know if the process of fertilizing the egg could be the reason for possibly damaging embryos. And if you could kind of explain if there are different ways of fertilizing eggs and how risky the process is.
So I think what might be interesting for her to potentially identify is the 3 subsequent cycles compared to the cycle when she was successful, whether, yes, about potentially fertilization, but if the embryos themselves were tested. So what's really, we think, more and more important, something that Dr. Tracaspa had alluded to, is this idea of pre-implantation genetic testing that really has become the standard, I would argue, for women in our 40s. We could debate probably back and forth, Dr. Tracaspa, if it's earlier, and probably it's in our late 30s, but I think most of us universally feel at 43, if she's not screening the embryos, that could be the huge disservice. So if she's in a series of fresh transfers, for instance, and the embryos haven't been tested, a lot of us go down this rabbit hole sort of as the individual experiencing this. Well, it's because of this, it's because of that. But if we don't know the embryo itself is normal, then that then in and of itself is most likely the cause. And so screening of the embryo becomes really, really important. The reason it becomes more important as women get older is, unfortunately, we are born with a fixed number of eggs that sort of stay with us our whole life. And they have greater likelihood of having error when we bring them on board in our 40s versus in our 20s. And the way to identify that error that occurs at fertilization, which is when egg and sperm come together, is going to be screening of the embryos. Depending on how you screen embryos, a lot of them want us to use a particular technique when we do fertilization called ICSI, which provides a way that it's 1 sperm and 1 egg. There was some data in the past when it was initially utilized, potentially for men with a very severe male factor, that it had certain risks that, given its prevalence in the more general population, not in the true severe male factor, I think is somewhat debated. But so I would sort of sway this question a little bit to answer whether the embryos are being tested. I think that's really where the information lies. And if they're not, that's what I would strongly, strongly recommend as a way to identify before a pregnancy is even attempted, where the embryo has an opportunity to be successful. Because at 43, an untested embryo, debate statistics, but it's going to be at highest 2 to 5%. That is not to achieve pregnancy. It's when you test the embryo and you know it's normal, we can now get success that people will argue the number, but 60, 70%. So I think testing the embryo is what's going to really help hopefully provide some answers.
Very good. Thank you so much. I think we're gonna, we have launched a poll to the patients, and now we're gonna look at the results from the poll. I wanted to remind you guys that this poll was launched early in the webinar, so it reflects the opinion before the webinar. We're gonna launch a similar one at the end and see the differences. Miriam, can you please read the poll for us?
Sure. The first question was asking if patients are currently seeking fertility treatment. We had 62% yes, 38% are not currently seeking treatment. The second question was if they're concerned about COVID-19 during their treatment. 73% of patients were concerned and 27% were not. And then we also asked what are the aspects that they are mostly concerned about right now. The high 40% of patients were concerned of risk of COVID-19 affecting pregnancy. 35% were concerned of the COVID-19 infection itself. 25% were concerned of risk of passing the virus to the baby. 33% were concerned with contracting COVID-19 during treatment. And then 38% were concerned of all of the above. And then we had 13% that were not concerned of any of these factors.
Very good, very good. So I am gonna share with you guys a publication that is related to this question, the last question. Riley, would you be able to share with us the publication, and then I will have the physician comments on it. And so while we're waiting on the publication to display, the publication is basically looking at 16 patients that were monitored during pregnancy, and they were monitored for, they have contracted at some point COVID-19 during their pregnancy, and then they monitored the delivery of those babies, and they also looked at the placenta during the pregnancy. I think the conclusion I draw from this is they have seen some lesions on the placenta. However, there is no evidence of a effect on newborn babies. And I will have Dr. Turkaspa comment on this, and then after that, Dr. Hirschfield.
Yeah, thank you, Nabil. I think this is a very important question. And of course, every paper, every manuscript that is published in a peer-reviewed journal will give us some additional information so we can conclude and recommend to the patients in a better way. Altogether, for now, there's no studies that shows that the baby was affected and that the virus was found, that the virus was transmitted during pregnancy from the mother to the baby. So yes, you can find, there is in the general state of the mother, if the mother is very sick, and we know about some possible for blood clots in the lungs and other tissues. So of course, we may find it also in the placenta. Nevertheless, none of those, when they report those cases, they did not report about that all those patients were actually needed to be delivered earlier because of some complication for the baby. So altogether, this is something that of course raise a concern. We need to follow up, but at the end of the day, this is something that from now on, nobody should get pregnant? No. When we look at the studies that published, there was just in JAMA this month, studies that looked at different patients that were sick with COVID-19, and they looked at different tissues to check and see whether they detect the virus in different tissues. And for instance, while they find 60, 70, 90% in the tissue related to the lungs and to the oropharynx, when they looked at the blood, they found only 1%, one specimen out of 307 that were positive. So altogether, and the virus needs to get through the blood to the placenta, and from there possibly affect the baby. This is not rubella infection. This is not Zika virus infection. This is not CMV virus infection. That all has been shown to significantly affect the fetus. This is a different viral infection that for now, we haven't seen virus detected with the embryo. There's been some studies suggested that there may be some immune abnormalities, that maybe some antibodies may have crossed the placenta, may have come. But right now, there is no, and the same thing with the sperms that we talked before. Even the study that showed some positive results within the sperm didn't show a virus that can cause infection. It shows some particles of viral DNA or RNA that may be positive with the testing that we do. So altogether, I think that while this study also brings support, we are having, there is a study that is running by UC San Francisco and it's now supported by ASRM and SART, and we have joined it, and I think many others, IVF centers done, that actually start following prospectively patients that are getting pregnant. So once they're getting pregnant in the first trimester, start to follow them prospectively, and then we will see those that unfortunately will be affected with COVID-19 and those that will not, and see whether there's a difference. Only those large-scale prospective studies will be able to give us some answer. But I think that as of how we should be concerned about it, should we continue to read about it, should we continue to educate ourselves about it? Absolutely yes. Is there a major risk right now that we should tell the patient do not get pregnant? Right now, there is none.
I just want to add that right there, you were just mentioning this research study that SART is behind. This is such an incredible opportunity for the patient population to be a part of what could be, you know, in many ways kind of groundbreaking, where you have IVF patients, infertility patients who can be studied regarding COVID-19 and throughout their pregnancy. And you have this audience, this captive audience of patients where we know before they've conceived, we know when they conceived, you know, we know when everything has occurred, and they are enrolling patients for this study. So I just encourage patients who are listening to this to ask their practice about it and how they can participate, because you know, we could really be the community that provides tremendous knowledge about this disease to pregnancy and to women around the globe.
Great.
Thanks, Barbara. Dr. Hirschfield?
And so I would really just concur with what Dr. Turkaspa said, that it is an initial study of only 16 patients. It's an excellent journal. In most common times, we would not feature an article of only 16 patients in any journal. 16 patients is more than 16 people watching this. And so I think what we need to better identify is exactly what was being alluded to, is how do we prospectively study large groups of women who are attempting pregnancy and achieving pregnancy, whether from IVF or not, to be able to establish relationships. And that is not something we're going to know in 3 months or 6 months. That's going to take years. I think it is important that preliminary data is incredibly reassuring. And I think it is also valuable. It's called ASPIRE, A-S-P-I-R-E. Your clinic can tell you about it, or you can go online yourself. But this is a way for all of us, all patients to proactively be part of the answer to how we learn what can this virus potentially impact, how can we learn about this as fast as possible.
Thank you so much. Riley, I think you can take that paper off. And Miriam, if you can give us another question, another 2 questions from patients. And I think you're muted, Miriam.
Sorry about that. Next question is from Alina, and she would like to get some advice on if you think a 41-year-old woman should do FET with donor eggs during COVID-19, and if that's safe.
Jennifer, please.
Do you want, I can answer, do you want me to answer? I think very honestly, to give a very thorough opinion, it would be able to sort of also look at your data, to be able to look at what your reserve is, to be able to look what other cycles looked like. If the question isn't, should I do donor or not, or should I do donor now, which I'm thinking maybe that's the question. I think the one piece about utilizing a donor egg is that it's not going to change in its success a year from now, or 6, or very honestly, years from now. And so it provides one of these unique opportunities to exactly what was alluded to before, that if someone is creating intense anxiety about being pregnant at this time, utilizing a donor egg is not going to change success for years. And so if seeing how in your own area or in our country, things change, whether in the state of Illinois, we are plateau, but we haven't dropped. I've had some patients who want it to drop before they feel more comfortable. I think utilizing a donor provides that some flexibility because the success maintains at a pretty high level, regardless of that woman's age when she does it. But I think that's the second part of the question, that she's asking less about if she should use the donor. If she questions about should use a donor, then I would encourage you, as everybody now in the whole world who's listening to this, is that Zoom consults can be done, across the country. You could call me, you could call Dr. Turkaspa. You don't have to live in Illinois where we both practice, and you could get a second opinion with someone who could really pay attention to your unique information.
Very good. Let's go to the second question.
The second question is from Camila, and she just wants to know, what if a patient does test positive for the virus? So what are the protocols that are currently set in place, and when would the patient be able to move forward with fertility treatment?
All right, so we have done some risk assessment and look at that, and taking everything together, including all the stress and everything that we talked about it, we would suggest the patient to cancel the current cycle, wait for 3-4 weeks, make sure that she's healthy and she recovered. And once we have done with that, make sure that she, and many times somebody that live with her, the partner, some kids, if everybody is healthy, wait 3-4 weeks and then move on for treatment. Definitely, I would advise her that for transfer. We would not do transfer if she was supposed to have a transfer in 2 days and we find out today that she's pregnant, that she's, sorry, we won't do it if she's pregnant, but if she's infected by the virus. This is common sense, If she would have a acute flu and she calls me 2 days before the transfer and she has 102 fever and she doesn't feel well and she's coughing and there's no COVID-19, even then we would discuss with her that probably it would be best for her to postpone the transfer. So definitely if she's infected with COVID-19. I think that taking everything together, now we've done a lot of work trying to get you not to get infected. Now you are infected with the COVID-19. Now we have to say, hold it. Let's not be a cavalier about it. Hold it, make sure you are healthy, and then go for treatment.
Very good. Before I ask you, Dr. Hirschfield, about the same question, I'm going to ask Chelsea, because Chelsea has expressed concerns that are, represented in that poll, the fear of contracting COVID-19 during treatments. Can you tell us a little bit about it, Chelsea?
Sure. I think right now, going into the frozen transfer, my biggest fear is contracting COVID-19, especially during that first trimester. And, what does that look like? But also, if I could add a sort of side question to that, everything that I've read about wearing a cloth mask is really, it's for those who are asymptomatic, so they're not passing the virus to other people. If people around me are not adhering to that, is wearing a cloth mask enough to protect myself?
So, in terms of the question about testing, I would say that we've taken a slightly different approach so that we are screening, I wouldn't say we're requiring, but there hasn't been one patient who hasn't wanted to. We are screening for COVID testing for all patients doing treatment, and we are following guidelines of Illinois Department of Public Health, CDC, et cetera. And there has been pretty well established guidelines for the context of which someone was screened for positive COVID and the time frame of which you should either do what's called like a symptoms monitoring or you should retest them. And so if we take asymptomatic, which is the majority of what we would see because we're screening people at the door, and we are not treating people with active COVID infections who are having difficulty breathing, et cetera. And the thought that was, or what has been recommended actually most recently by the CDC is 2 weeks from initial testing, theoretically somewhere 2 weeks from treatment before someone can re-enter society. And if someone had a positive test, interestingly, the follow-up can vary depending on when the symptoms initiated, when they resolved, either it's time that sort of that has to pass before someone re-enters society, so to speak, or they get retested. If someone's asymptomatic, it's no longer recommended to retest them. So if somebody was actively identified as positive, the whole purpose of us doing this screening is to encourage that person to not do treatment. And the purpose of doing screening is twofold. Number one, it's to be able to guide someone to mitigate some of the anxiety. And so when it's our fresh IVF cycle, based on guidelines as well, we're trying to screen people in a 2-week window. For frozen embryo transfer, we do it at progesterone start. We are doing the PCR-based test. We get our results in 3 days. So it has been feasible. We have identified asymptomatic individuals. We then will use the asymptomatic CDC guideline about when they can quote unquote re-enter treatment in the context of when they could re-enter society. I think the goal would not to be conceived when you're active COVID. The other secondary benefit is the more people we screen, the safer we feel our office could be. The questions we do not know is, okay, we're doing the PCR-based testing. When do we add in the antibody testing? Is it every 2 weeks indefinitely? Is it every 2 weeks in this interval? There are so many questions that I think, to what Barbara had said, things are like going so fast that I do think weeks to months, these protocols will be even better defined. I think in terms of your question, Chelsea, about the mask, I completely agree with what you're saying. This is where we're sort of that, it's not just like a phrase, we truly are all in this together. So if the person next to you is out all night doing who knows what, kind of with a bunch of people, and then they come in, they don't wear a mask, yes, that is not optimal. And this is where that 6 feet comes in. So to try to find a way in a work environment that you are truly 6 feet from someone who's not wearing a mask. You can theoretically be closer if you're both wearing masks, but you're right. Someone is not wearing a mask, is putting you at risk. That's not a safe work environment. I think I completely agree with the hesitation the first trimester. I think hopefully the messaging that you've heard from both Dr. Trokaspa and I is that overall it's quite reassuring in terms of the initial data in COVID-19. It's a scary and unknown time, but the initial studies are reassuring. And so to try, like I had said before, that in that first trimester, I wouldn't be the one who went to the grocery store. Places open up, if it's 25% capacity in the restaurant, I think I'd take a pass still. I'd be even more cautious. But I think that taking everything as an entity, that the overall it's much more positive than negative.
Thank you so much. Barbara, what do you hear from patients? Do you feel there is a concern about contracting COVID-19? What do you hear from patients?
Yeah, what we're hearing from patients is just, is it safe in the clinics? What kind of procedures, what are the protocols? How are the staff being tested? Are they letting us know if a staff member has tested positive? How is that being dealt with? I think patients, they are excited. They are wanting to get back into clinics. This shutdown was devastating to many patients, not all, but to many patients. And so you've got patients who have that kind of pent up demand and are wanting to get right in. And then there's another group of patients, I don't know necessarily what the numbers are, who are cautious and who are nervous and who are wondering, what's it going to be like when I walk in, and will I potentially contract COVID at this IVF clinic? So I think, again, I hate to say it, but over communicate. How are the practices letting their patients know what they're doing, how they're keeping them safe, how they're keeping their staff safe, and what that experience will be like. I mean, whether that's a short video, whether before a consult, there's somebody that sort of walks you around via Zoom. I mean, let's get creative. Think about how we lower that anxiety and set those expectations so that patients have a sense of what's going on behind those doors and how I'm going to feel. Now, a lot of the patients you're seeing now have already been in your practice. And so there's this before and after, but you're going to have patients pretty soon who've never walked in your door. And you've got to really be thinking about how are you providing them that level of confidence and comfort that what they're going to experience is going to be safe for them. I've heard from a lot of patients who are like, are the clinics going to keep it quiet if one of their staff gets COVID? And, you know, are they going to hide it? I mean, there's this concern that I think we need, again, to learn some extra steps in transparency that we haven't really had to think about before.
Very good. Thank you so much. This is really great, a great discussion. I think we are getting a good feedback from patients and physicians at the same time. We are going to, before we go into the results from the poll that we released, you know, the poll that we have just released has been released, or we have asked IVF personnel how they're handling, you know, the laboratory aspect in terms of what disinfectants they are using. Are they using PPE policy? Miriam, can you read for us the outcome of this poll?
Yes, we ask if clinics are currently operating, and once again, this is a poll for IVF professionals that are attending our webinar. 88% of clinics said yes, and 13% said no. We also ask what disinfectants they're currently using in the lab. 58% are using hydrogen peroxide, 46% are using alcohol, and 13% are using bleach. And we've also asked if they've changed their PPE policy during COVID-19, and 88% of attendees said yes, 13% said no. And we've asked if they changed their SOPs in the IVF lab in response to COVID-19. And it was a similar response, with 88% saying yes and 13% voting no. Very good. Thank you so much. We have noticed over time how clinics have moved from not operating to operating. I remember the old polls, they were in the 30%. Now we see almost 90% of the clinics operating, which is, you know, refreshing to know. But as far as SOPs and PPE policy, I want to get your feedback as clinics, what you guys are doing to minimize exposure. And I'll start with you, Dr. Turkaspa.
Right. So we start from the scheduling. As before, patient used to come in a different time and come for monitoring between certain hours. Now it's only time. And we ask them to arrive on time, not to come, if they arrive earlier, to wait in the car. If they arrive late, they need to call and to see when should they come up, and they may wait a few minutes, or they may wait half an hour to an hour because other people came on time. We took half of the chairs in the waiting area. So now it's 6 feet between each chair. We took all the magazine out. All the cups to drink water out. When they come in, first of all, when we remind them the appointment, we ask about all the symptoms and everything and remind them when they should not come. When they come in, we revise it with them. We check the temperature. The same, by the way, applies to staff. So when I walk to the clinic, I walk first, I wait, they ask me, are you okay today? They check my temperature, only then I'm going in. Now they will wait for a few minutes and they go for blood draw. From there, they will go for ultrasound and they leave. Unless they need to have like a saline infusion sonography test to evaluate the uterine cavity or endometrial biopsy for assessment of the uterine receptivity, thing like that. Everything else will be done either by video or phone. If they need procedures like hysteroscopy, then it will be scheduled with the surgical center. If they come for egg retrieval or transfer, now they usually will see the friendly face beside ourselves, the friendly face of the embryologist that will ask them, verify their identity, and then now they will see somebody in a mask. And distancing as much as we can in the room when we do the transfer. So I think that if your IVF lab already used to work with masks and everything else, then they don't have to change a lot. I mean, they may change the policies and procedures, but they're already doing everything they should do. Even in the lab, we would try to space as much as we could from different people. And sometimes all you need is just to move one incubator to one incubator to this side, and to move one working station to another feet or two to the side. So those things can be done. We minimize the staff personnel that are in the clinic. So instead of 20, 25 people, you may have only like 5 or 6 or 7, and that's it. So it's worked very, very good. From the patient point of view, it's very efficient. Once they come, we concentrate on them to provide the service they came for. If they have any questions, they can, but if not, we encourage them. They can have a phone consult or video consult with the physician the same day or the next day with regards to everything they went through. So it's, from as far as we can say, and what the feedback that we get from our patients, they are very satisfied with the procedures that we put through. We had close to 40 patients today in the clinic. I was there seeing 6 patients. Then I did a phone consult, then I did surgeries, and I'm participating here. So, you know, everything is working fine for now, at least.
Very good. Thank you so much. Dr. Hirschfield?
So in terms of changes that we've made, so same idea that we're incorporating social distancing, that we've marked on the floor where people can stand. When you enter to our clinic, you answer the questions, your temperature is checked, same with staff. In terms of things like minimizing that you're going to touch a pen, any copay is collected before you come in. So we're trying to minimize that you have to touch or really interact in that way and anyhow to minimize, again, theoretical risks. In many of our offices, we've incorporated plexiglass. You're 6 feet away from the person in a mask who checks you in. You come through. We have staggered our ultrasound and blood visits so that we're limiting anybody in any one space at any one time. Absolutely changing the way our wait rooms work. If for some reason there was someone who came late, then sometimes they are waiting in their car until they get called that appointment time is available. We do not allow patients to bring partners or children or friends. They must come on their own. They must be wearing some type of mask. When we do our procedures like saline sonograms or retrievals or transfers, in addition to staff wearing masks and physician wearing masks, we're also wearing those plastic shields that have been recommended by the CDC. Ultrasound techs have been recommended to do that as well, and they are in the context of our saline sonograms. And so I think that when we think of the PPE, that might be the newest piece. We were a clinic that used masks already, and our staff and our embryologist did. We are using sort of the straightforward surgical mask. We had a nurse who very generously sewed masks for every single member of our staff. But we are not trying to take away an N95 mask from where they belong, which is someone in the ER or someone who's actively taking care of patients who have active COVID infection. And I think that's really the balance. And I think that's what ASRM identified in their guidelines, is we can't, as clinics, be taken away from those truly on the front lines. And I think that's really, really important. So we are not incorporating N95 as a universal type of mask.
Thank you so much. Barbara, do you feel the physician have addressed some of the concerns that you hear from the patients? And what would you like to happen as far as the communication between clinics, physicians, and patients?
Well, I mean, you know, certainly the 2 practices we've heard here today are doing a tremendous job of ensuring the safety of not only their patients, but their staff. And, you know, at the end of the day, that's what patients want. I think, you know, what I would love to see in a perfect world is for every practice to, you know, get creative and to recognize that while they may be doing it all right and well, maybe they haven't quite communicated that to the patients that they're seeing. I mean, you can easily survey your patients. You know, you can survey them after they've left your practice and send them a quick email survey that starts measuring, you know, the kind of, how did you feel before you came in and how did you feel after? Did you feel that you were provided with adequate information about what your visit was going to be like and how we were protecting your health? And then, you know, afterwards, did we live up to the standards that that you are expecting and want to see? You know, one of the things that you hear in the news is that you hear and you see on, you know, on you know, people posting is when they catch somebody not wearing the mask. They catch somebody, you know, talking and being close. Your patients are going to notice that. If they see staff members, you know, chatting down the hallway and there's 4 or 5 of them, or they walk past an office and there's a bunch of people, they're gonna see that and they're gonna say, they don't want me to see that, or what was happening there. So I think that you've got to be on guard, but not in an adversarial way. We're all, as Dr. Hirschfeld said, we're all in this together. And so how can you be creative in how you communicate to your patients, and how can we assure our staff that that we're doing the best for our patients, and vice versa. I think that if patients feel, wow, I felt really cared for, I felt like it was a really safe environment, then their anxiety is going to go down, and they're going to be more likely to continue on this journey. The old ways are out the window. We have to start thinking new and different, and really, quite honestly, meeting needs of patients that are right now extremely high.
Fantastic. Thank you so much. Chelsea, do you feel your concerns have been addressed in some ways? And do you have any other comments to add?
I do. I thank you for including this focused on the patient perspective. I think that my experience has been a little bit different than maybe what Barbara was describing, though I completely agree with everything that you said. I am vastly more concerned about the general population's behavior versus the clinical experience. But given that I have not been to my clinic since the start of the stay-home order in my state, so that could change when I go back. But I think that the more information that we have, the more communication that we're getting from our clinics, the better off that our mental health and just our general well-being will be, because of the importance of having that relationship. And that goes throughout the entire cycle, but definitely during the global context that we currently have with the pandemic.
Very good.
Can I just make a note? So that's a perfect example of what we all need to be thinking about. So you can control what's happening inside the 4 walls of your practice and your SOPs and your PPE and your practices. But what Chelsea is concerned about, where her anxiety lies, is what we can't control. It's all of the things that are going on when she goes to the grocery store, when she, you know, goes out in public, or tries to go out in public. And so this is our new reality, is that you can say, oh, it's safe, we're here, we care about you, and we know that, and you do. But layer onto that, wow, they're looking at things on the news, they're seeing what might be happening down the street from where they live, and that's stuff that you know, we can't control, but we have to be aware that that's what our patients and our future patients are living in. So really, gosh, these are tough times for all of us, and I think the more we listen and the more we think about kind of where those patients are, the better off we're going to be in meeting their needs.
Thank you so much. Well, we have asked the patients that have attended this webinar about social distancing and as far as practice, and also what they feel about the webinar value, education value. And Miriam, can you read the question, the answers 4 to 6, the last ones?
Sure. We've asked if patients have been practicing any social distancing, and 85% of patients said yes, 10% said somewhat, and 5% said no. We've also asked how important they think COVID testing is during fertility treatment, and 74% of patients felt that testing was very important. 23% felt that it was somewhat important, and 3% not important. And then we've also asked if the webinar has clarified any of their concerns about COVID-19, and 74% said yes.
Very good. Thank you so much. We have also asked our IVF professional a few questions, and we have a poll results. If you can read that for us, Miriam.
Yes, we asked how they screen their patients. So this was a multiple choice question. So 82% said temperature and symptoms, 32% RT-PCR, and 36% used antibody test. And then we also asked them how valuable the webinar was to their IVF practice, and 77% said that it was very valuable.
Fantastic. Well, thank you guys for providing such a quality webinar. You can see how people are reacting. They obviously see value in what you guys are saying. We are approaching the end of the webinar. I want to take the opportunity to get you guys introduce your practice and tell us what you do, so that all the patient will know about you as far as practice. And Barbara, you can also talk about what you guys doing as far as mission and your goals, etc. And I'll start with you, Dr. Hirschfield first, and then I'll go with Dr. Kaspa and then Barbara.
Great. Well, thank you again. This was incredibly informative. I think my one question remains for Barbara about how we best should communicate. If it should be social media or emails, just because when people look at email open rates, it's not great. But thank you. I feel really inspired to come up with clever ways of demonstrating what we're doing. My name, again, is Jennifer Hirschfeld-Citrin. I'm a physician at Fertility Centers of Illinois. We have 9 locations throughout the Chicagoland areas. We have contracted down in the context of COVID. FCIonline.com is how you could find me.
Very good. Dr. Kaspa?
I'd like first to thank Barbara and Resolve for everything that you guys are doing. I mean, Resolve is an amazing organization that support patients during this journey of infertility. So first of all, thank you. And it's been difficult for you guys to support everybody else. So you've been doing a great job. My name is Ilan Tokaspa. My partner is Dr. David Cohen. We both practice in Chicago, Oak Brook, and Indiana. We're a boutique clinic that serve patients that comes from all over the Midwest and the US for infertility treatment, as well as for pre-implantation genetic diagnosis. We are specifically keen of not just testing genetically the embryos, make sure it's normal, but also to focus on the uterine cavity and make sure that the uterine cavity is normal and ready. So our website is Infertility IHR, Institute for Human Reproduction, infertilityihr.com. And your success is our success, so we wish everybody a good outcome.
Very good. Thank you. Barbara?
Yeah, so Resolve is Resolve, the National Infertility Association. We're a nonprofit charitable organization, been around for over 40 years. I'm based outside Washington, D.C., and we are known for having support and online and in-person support groups. We do a tremendous around public awareness. We launched something called National Infertility Awareness Week about 30 years ago that we just celebrated in April. And then we do a tremendous amount in access to care, whether that be with state legislatures, the federal government, or with employers. And we have programs that do all of that. We had almost 400 advocates last week talking to their members of Congress about issues that are important to our community. We help get state insurance laws. Illinois, we helped with, along with a number of advocates, and most recently this year in Colorado. So we also helped get surrogacy legal in the state of New York. So we are really about family building and access to care, but we are a charitable organization. So we survive on contributions from individuals and corporate support and physician support. And that's how we're able to do what we do. And so, but, you know, if you're a patient, go to resolve.org. If you're a provider, tell your patients to go to resolve.org. One of the most empowering things that people find is giving back in terms of volunteering as well as advocating. And it's a way to get a little bit of control back from a journey that doesn't provide a lot. So myself, I've benefited greatly from Resolve during my own infertility journey and love this organization. So, but I want to thank all of you for sharing today and your support of Resolve. And Chelsea, I wish you the very, very best. And if we could go mask every single person out there and keep them 6 feet away and put you in a big bubble, I would do that in a heartbeat. But I feel for you, and just hang in there.
Thank you so much. Thank you. Chelsea, any last comments?
Just thank you for all that you do. You know, we've said multiple times that it's such a roller coaster, but it's because of people like you who care about the patient perspective that, you know, we are able to have success stories. So hopefully I'll be able to share mine soon.
Very good. Wish you the best. Well, we are coming to the end of the webinar. Thanks to all of you for providing your perspective on patient care. As far as Barbara, thank you so much for providing the advocacy aspects and your support to patients. Chelsea, thank you so much for bringing the patient perspective. Next week, we will have another webinar on the patient as well, on the patient perspective, maybe a different topic. Stay tuned, check your email, and I will see you soon. Thank you so much. Thank you.
Bye. Thank you.